Okay, good morning. Welcome, everyone. This is the Palliative Care Benefit Work Group. So if you're looking for this meeting, you're in the right place. Hope everyone's doing well amidst our legislative session and enjoying the spring weather. As a reminder, my name is Nico Jansen. I'm the Senior Health Policy Analyst for the Office of the Insurance Commissioner, or OIC, and I'm OIC's lead for this work group. We're going to begin today first with a land acknowledgement that I'll read. We are meeting virtually from Olympia and Tumwater on the traditional territories of the Coast Salish people, specifically the Nisqually and Squaxin Island peoples. Olympia and the South Puget Sound region are covered by the Treaty of Medicine Creek, signed under duress by the Coast Salish people in 1854. The Office of the Insurance Commissioner and Washington State employees respect these lands and tribal sovereignty. We acknowledge the tribal governments and the Coast Salish people living on and taking care of these lands. Okay, so before we get into our presentation for today, I'm going to recap a bit of the background for everybody and what we hope to achieve for today's meeting. I know it's been a few months. We last met in January, and I know that we all have very busy jobs and busy lives. So as a refresher, the reason we're here is to advance our work that the legislature has directed us to do to design the parameters of a palliative care benefit. Crucially, the legislature gave the OIC funding to contract for an actuarial analysis as part of this. So that concerns estimating the potential cost of establishing a palliative care benefit, including any impact to per member per month premiums, actuarial values, et cetera, looking at those issues. This is applied to both the fully insured commercial health insurance market that the OIC regulates, and we've expanded the scope working with the Healthcare Authority as well as Milliman to also include Medicaid in this analysis and in the scope of this work group. In our last meeting, we had a number of great presentations, and we established generally that we are going to use the previous recommendations and kind of framework for a benefit that were established by the BRE Collaborative on a work group on which some of you served, and the Healthcare Authority and OHSU report recommendations from a few years ago. Look at those, that framework for a benefit as our starting place to inform our analysis that's going to go into this report. So that was our last meeting in January. So that brings us to today. For today, we are going to have our contracting actuary, our consulting actuary, Milliman, led by Matthew Smith and his team at Milliman, present their work to date to this group. And so my goal for today is for you to hear from Milliman on the general direction that they're going to be taking with their analysis on our behalf. I understand they're going to be talking particularly about the clinical eligibility criteria, that is, who is eligible, how they become eligible for palliative care services, and then the services included in a palliative care benefit. And I understand that that's a particular emphasis because those are two of the parameters that the legislature directed us to include that really are going to drive this cost analysis for the benefit more than some others. I also understand that the payment methodology and our what we contemplate around reimbursing with a mix of fee for service or alternative payment models is also going to drive that. But I understand that Milliman's going to be delving more into the payment methodology at a later time. So their presentation today is not going to touch on that quite as much. So after this meeting, I'm going to resend all of the workgroup members this draft that Milliman is presenting on today. And I'm requesting that our workgroup members and any other interested individuals involved in palliative care work send me any input you have on the direction Milliman is taking in writing by the end of April. I'm happy to get on the phone with anyone and engage with anyone. But basically, after the presentation today and your opportunity to ask questions, give feedback for us to have a general discussion, I am giving everyone until April to give them some initial feedback. Throughout the spring and the summer and fall, we have a work plan developed with Milliman and we have some specific dates. So this isn't the end of your ability to engage and give feedback. We're going to have future times where we give you more of the draft work that's being done for you to give us feedback on. That includes having an opportunity to review the final draft report that we're giving to the legislature. And as a reminder, that final report is due to the legislature November 1st of this year. So that's kind of the time frame that we're on. So with all that having been said, I'm now going to give the floor to Matthew and for him to introduce himself, his Milliman colleagues, and present on their work so far. And I encourage folks to ask questions. You can use the raised hand function during the presentation if you have a question or a comment for Milliman and the team. So with that, Matthew, I'll turn the floor over to you. Thanks.
Sure. Thank you very much, Nico. So just to start with some intros, and then we'll get into the content. So my name is Matthew Smith. I'm a consulting actuary based in the Phoenix area. For the last few years, I've worked with multiple clients to better understand the needs of informal caregivers and support both caregivers and care recipients. As part of this work, I've engaged in in-depth research and spoken publicly at length on this topic, in particular for the Society of Actuaries. And I've also written about the emerging guide model, which is focused on dementia and the informal caregivers of people who are experiencing dementia. This focus on caregiving I found to be a valuable source of insight, especially into some of the palliative care work on this project. And I'm looking forward to getting to know and continuing to work with everyone here as we move forward on this. Sherry and Shelley, would you like to go next?
Sure. Thank you, Matthew. Oh, go ahead, Sherry. I apologize.
No, I can't see everybody's face on the screen. So my name is Sherry Dodge. I'm a nurse by training. I work out of the New York, Atlanta practice at Milliman, and I'm on the clinical team. Nice to meet you all.
Great to meet all of you. My name is Shelley Perino. I am in the Seattle Health practice, but work from my office in New Jersey. And I'm also a registered nurse by background with a master's degree in public health and have been working in managed care for over 15 years with a particular emphasis on case and care management.
All right, thank you both. I am going to just give me one quick sec and I will just put this on display. Can people see my screen?
Yep, we can see it.
Okay, so this is the title screen of the report that we had sent to Nico, and Nico, I believe, is distributed to the work group in advance of this call. I'm going to talk a little bit of background and some high-level information, and then Sherry and Shelley are going to talk some particulars about what's in the report. And then once we've gone through that discussion, we'll have time for your discussion and Q&A. If you've got questions as we go, feel free to raise your hand, and we will try and answer those as those happen. Let me just tweak my meeting window so I can see that again. Perfect. All right, so just introducing what we've been doing on this report as well as the overall direction of things. So our support of OIC and the work group is going to ultimately involve producing a report that will be submitted to the state, as Nico mentioned earlier. This report will primarily involve actuarial projections of the potential cost of the addition of a new palliative care benefit. It's also going to contain multiple other considerations, in particular, some of the ones that we are going to be going into now, plus some other discussions, particularly around payment methods. For this group, we have recently provided our first preliminary draft. This report specifically focuses on staffing, training, evaluation criteria, reporting requirements. It also provides some of the parameters we intend to use in our upcoming actuarial analysis, specifically in terms of clinical eligibility criteria, as well as which services could be included in this palliative care benefit. The information provided on these two topics has primarily been based on what was included in the palliative care report published by the Robert Breed Collaborative, with additional data contained in the Washington State Palliative Care Reimbursement Summary Report published by HCA and the Oregon Health Sciences University, as well as other sources where relevant. Our intention here is for the contents of this report, pending feedback and discussion from both OIC and this work group, to be part of the ultimate report provided to the state, both in terms of the contents that you see here today, as well as in terms of underpinning the actuarial analysis we will be engaging with over the next few months. Today, we'll be providing some brief discussion around the contents of our report, as well as allowing everyone an opportunity to discuss and have us answer questions. You'll also have the opportunity to follow up with Nico to send questions and notes for our considerations after this call. Please do note that while we have provided information for the work group's consideration, before we do specific data analyses, we're relatively limited in the conclusions we can make about the data since we haven't yet studied that. Also, as discussed in our draft report, we are not designing or recommending design features as part of our work. And finally, we do anticipate that this draft report may be revised by the time the final report is published. For instance, in response to any questions, comments, revisions, or suggestions you may have, or any internal revisions we may determine are appropriate based on the continuation of our work. Any questions relating to that, or should I move on to Sherry and Shelley's sections?
I guess I would just clarify, well, reinforce what Matthew said. So the idea here is Milliman's doing the actuarial analysis for this group, and OIC in consultation with this group is working with Milliman to determine what assumptions they're going to make, right, to do their analysis. So I think some of the policy choices we're going to be working on to give Milliman so that they can do the analysis.
Yep, absolutely. Sherry, would you like to go next and give a quick discussion of your section, and then Shelley can follow, and then we can get into the group discussion and Q&A?
Sure thing. Thank you. All right, as outlined in the statement of work, the initial task related to the patient eligibility criteria and covered services was to review the reference documents mentioned by Nico and Matthew. For clinical eligibility, our target population for the palliative care benefit includes individuals with a condition that negatively impacts their quality of life or daily function, is burdensome in symptoms, treatments, or caregiver stress, and/or carries a high risk of death. In alignment with the reference documents, we developed a code-based logic to identify eligible adults aged 21 and older who are not receiving hospice services. The clinical eligibility criteria includes 3 required components based on the criteria from the reference documents. And these would be applied for both lines of business, so both the fully insured as well as the Medicaid books of business. The 3 requirements, the first includes a serious illness or multiple chronic conditions. Eligible patients must have at least 1 serious illness that has progressed to a stage where avoidable complications are common, or a combination of 3 chronic conditions. Examples of serious illnesses include metastatic cancer or advanced heart failure. Examples of chronic conditions include coronary artery or peripheral vascular disease. And these illnesses and conditions were outlined in the reference documents. The second requirement for eligibility includes a substantial functional limitation. This is where patients have a need for assistance with 1 or more activities of daily living. Limitations related to activities of daily living include bathing, feeding, and mobility. Patients with a reliance on a durable medical equipment, such as a hospital bed or home oxygen, also meet this requirement. The third and final requirement for meeting clinical eligibility criteria includes a recent emergency department or acute inpatient hospitalization that is unscheduled. So this could include hospital visits such as ED, observation stays, as well as acute inpatient admissions. Scheduled hospital utilization, such as the administration of chemotherapy, does not satisfy this criteria. These criteria, these 3 components, are kind of the core foundation of our patient eligibility criteria and are outlined in the reference documents. I'd like to pause here and discuss any comments that you may have about potentially over-identifying or under-identifying patients who could be benefit from the palliative care services.
So Sherry, excuse me, in my reading of the Bree Collaborative report, I think that they put in the appendix this PAXI eligibility tiering
Right.
model, and I read that to um basically require the multiple criteria to be met for eligibility. As in your so in Milliman's work so far, would you say that this list is fully consistent with that model? Are there differences? Are there, I don't know, areas of that that were uncertain?
Our model is consistent with that, where we identify degrees of these three criteria to assign patients to a tier 1 or tier 2 complexity. That is consistent with the PASI model. So those tiers could be used to establish payment tiers based on patient resource need if desired. So yes, the tiering is built into the model based on the complexity of the patient based on these three criteria.
Wonderful. Okay, thank you. That's a great clarification. We have a question from Carla in the chat. Why does the age start at 21 and not 18? I'm just going to say in my reading of the Bree Collaborative and OHSU, I think that they referenced that they didn't feel as though a new benefit was necessary in the same way for the pediatric population as adults. I think they kind of separated that. I know some folks here served on that and have expertise, but anyway, that was my reading of that. But yeah, could you address the question of why the start at age 21?
No, that's a great question, and I have that on my list as well. So one of the reference documents was the Washington Palliative Care Summary Report, and I believe it was outlined there that perhaps the state Medicaid plan had methodology and a benefit for children under age 20. And so that was one of my questions actually for the work group. Could you, is age 21 what you would like us to work with for this analysis?
And one thing I just want to supplement that with is part of our analysis is going to be testing alternative criteria. So this may well be something where you have an idea of what might be a default type of benefit assumption, but if you wanted us to test alternative age limits, if you wanted us to test what if it's no age limit, that can be done. Part of what we want to get out of this discussion is to make sure that we understand the various things that you're looking at in terms of what is valuable to be testing against, because what are some of the things that the state may be considering, do it this way or do it that way based on potentially the overall cost and utilization of it. So this struck us as one of those that in particular could be tested against relatively straightforwardly, but we wanted to understand what your thoughts on that were.
So I'll throw it open to our work group if anybody has feedback on this age issue we're discussing. And if you don't today, that's something that you could absolutely submit to us, in the next few weeks. So let me just throw it open while we're on this topic, because I think it's a good one.
I put it in the chat, but I can also just say that I wondered the same if the age cutoff wasn't considering what benefits are available to Medicaid clients. But since this is also looking at the commercial market and that fully insured portion of the commercial market, it might be beneficial to consider the adult cutoff or the cutoff to be 18 for adults for that purpose. Because I don't know that there isn't everybody that's in the commercial market doesn't have access, obviously, to the Medicaid benefit.
So Heather, you're saying for fully insured commercial, assume eligibility starts at 18. Is that what you're saying?
Right.
Okay.
And help me understand better why adult only. The pediatric population is small, but their acuity and the need for services is substantial. And so just trying to better understand why we're excluding that population.
Carol, I'll defer to you with your experience. Thank you.
Again, I think this is really about the use of the reference documents in their context and their application here. These are questions we had. I will comment that I happen to be a pediatrician. I'm a physician, do a fair amount of work in the palliative care space. The current criteria that are referenced in those documents about what does it mean to have a serious illness and what does it mean to have multiple chronic conditions are not really well suited to identify the appropriate children beyond cancer. That is picked up but for a lot of the other children who might have substantial palliative needs, they wouldn't be identified. And so I think this is a point of discussion for the group. And like, what would you like us to work with? We can work with the preferred approach for children. And I do understand there's an interface with other types of benefit categories in certain markets that has to be considered.
In general, I mean, we were going off of the BRE collaborative and the OHSU documents when they talked about recommendations applying to the adult population. So
Nico, one thing to consider here is that especially for individual and small group and actually large group as well, we have a state non-discrimination statute, and our state non-discrimination statute prohibits discrimination based upon age unless there's a clinical justification for the distinction. So I think for the commercial population, we might need to include kids if we're talking about a benefit design question.
okay. Barb, did you want to say something on this, on the age issue?
Yeah, I know this benefit or that we're talking about is not necessarily for Medicaid covered beneficiaries, but the current pediatric palliative care coverage under Medicaid says it's for peds patients age 20 and younger. So then there could conceivably be this gap for a 20-year-old who isn't old enough for this new benefit. But, you know, if they had Medicaid coverage, they were also too old for the Medicaid palliative care benefit. So I just wanted to point out that discrepancy.
Okay, thank you, Barb. And Medicaid is now within the scope. I mean,
Okay.
we were able to do that,
Okay.
Which is good. So I appreciate that. I mean, I'm hearing that this is something we may need to alter in the design, right? This is an example of where we have what previous work groups have done and the recommendations, the framework, but we may need to adjust that or at least model multiple scenarios.
Right. And Barb, in terms of the Medicaid benefit, if it says 20 and younger, that means it's up to the day before, I think it's up to the day before you turn 21. And I think that's rooted in Medicaid EPSCT. But we can confirm that.
Hey, Nico and Jane.
Yeah, go ahead, Drew.
Just to get sort of past this age piece, can we just call this an adult palliative care policy or program? And that, because I think peds is a very different beast when you're talking about palliative care.
Drew, clinically, I agree that it's a different beast. But if we were to take this to the legislature and the legislature and advocates were proposing the inclusion of, for example, a hospice benefit in the essential health benefits, the legislature would need to look at kids as well as adults. And even under our state non-discrimination statute. So it's a little, given that, it's I'm not sure whether it makes sense to carve out kids. It definitely does for Medicaid because it's already a covered benefit. And I guess the question to the Milliman folks is, you know, as Drew's saying, if it's a different animal, how different is it for you in terms of your modeling if we're bringing in kids on the commercial side?
I mean, what I would say is the current identification criteria for serious and chronic illness are really premised upon an adult population. And so we would want to make sure if we wanted to bring in children in a commercial population, we would need to revise those criteria to make sure we're including the types of conditions that children beyond cancer, which is comprehensively covered, need. And then we would potentially need your guidance on whether the types of criteria that we apply are really relevant to a pediatric population. So I'm thinking about like young children with complex congenital conditions that might be life limiting. Some of the concepts and the ways we identify functional impairment, for example, like how would we replicate those? We certainly could replicate the diagnosis, you know, with the right list. We could include utilization, you know, hospital-based utilization, ED and inpatient visits. It's a little bit, I have to think about like what that would mean for a 2 or 3-year-old and what would a functional limitation, for example. The current requirements require like things in all of those areas. They're really focused on what we would consider, you know, adult limitations. And those may not apply well to particularly a young pediatric population. And so we would need to refine the criteria to be sure we were identifying the subgroup of the group of children in the commercial side if there's already a benefit in Medicaid that we're picking up children who would be eligible for this. So that's on the who would be eligible side. There may also be some sort of considerations that need to be done on sort of the utilization of the services, but we haven't gotten to that part yet.
Yeah, Carol, I think on the utilization on the page, you know, about the, you know, private duty nursing use may be much more common than, you know, an inpatient admission or an ED visit, and clearly,
Right. So I think you're saying like even having utilization criteria, for example, that we might have for adults might under-identify children.
Yeah.
And so we'd have to think about, did we have to, you know, adapt the criteria, not just and maybe, you know, reconsider whether their functional limitations or inpatient or hospital-based utilization required, and potentially just rely upon serious diagnoses, which is certainly possible to do that.
Would it make sense to check in, and Heather, maybe you could help with this, would it make sense to use the same clinical eligibility criteria for kids that Medicaid uses to have consistency across? What do you think?
Yeah, that certainly makes sense. So if that's something that I can take back to get a sense of what they're using.
That would be super helpful, Heather. Thank you.
Yep, happy to do it.
Yeah, I think the how is something we can work out offline. I think the key element in my mind is I wouldn't want to exclude children. I feel like that is an important enough population. Finding out a way to integrate them into this work would be important.
This is great, and this is an example of what we want to bring to the group to inform the analysis. So I'm hearing in general, we do want to model the benefit to include pediatric population. We may have to develop a different eligibility criteria in doing that. We may be able to try to align that with how the Medicaid benefit works now. So I think that's a good, you know, change to make, and we all can work together to detail it out a bit more. I'm also seeing here in the chat a comment from Jamie, which is really helpful context, which is saying that the OHSU report that we've had Sophie present on to this group was intentionally focused on the adult population because there's an existing pediatric palliative care benefit for Medicaid. So that makes a lot of sense as well. And I take Jane's point very strongly in terms of avoiding discriminatory issue as well. So that's what I'm hearing from the work group for this direction to include the pediatric population, what we model. Is there any other discussion, questions on this topic, the age topic and kids and adults before we proceed?
I have one additional question that's related to the eligibility criteria regarding patients with dialysis. In the reference reports, each of the organizations kind of handled patients with dialysis slightly different. Patients with end-stage renal disease is part of the serious illness criteria. Do you have a different program or model that you use for patients with dialysis that we need to be aware of?
Do any of our work group members, folks on the call, have any initial thoughts on that question? And if not, you can get us feedback in writing by the end of the month on that as well.
I'm not familiar with any separate dialysis pathways or protocols. I will say dialysis is a challenge in the hospice realm in that many patients would be very appropriate to be on hospice, but they have to give up dialysis for most hospice agencies. And so there is a role for palliative care to be able to serve dialysis patients who aren't ready to stop dialyzing and therefore are not hospice eligible.
Thank you, that's helpful. If there are no other questions, I'll move on to the covered services.
Actually, Sherry, do you mind if I pop in for one quick sec? So one of the other things that we wanted to get feedback on relates to the frequency of reevaluation and the length of episodes. So right now we set this as 6-month episodes with a to be determined criteria for reevaluation afterwards. And I think there's a question of how stringent we want that reevaluation of eligibility to be. Is this something where, for instance, we do a full refresh of all of the criteria up here for eligibility? Is this something where we potentially do a continuity of care, maybe a lower eligibility tier of, you're not having healthcare utilization because your interventions are helping to stabilize things. This is something where it's likely to have a material impact on the overall program costs. And this is certainly something where we can be presenting multiple options and studying, if we do it this way, if we do it that way, what would it potentially look like under those various scenarios. But I wanted to have the group start thinking about what are your intentions and your preferences in terms of what eligibility reevaluation at the end of an episode period ought to look like. And again, this isn't something we need an answer on today, but we would like some feedback over the next couple of weeks as part of that overall discussion, since this will substantially inform our overall actuarial analysis.
Well, you called out something I think is important, which is the reevaluation for eligibility probably needs to take into account the impact of the intervention itself compared to the initial assessment for eligibility. And what I mean by that, for instance, we have a palliative care team in Columbia County around Dayton, so a very rural community. They've had multiple patients that once they enrolled in a combination of a complex case management and palliative care model, their ED utilizations and hospitalizations drop off substantially. If we go back to the original eligibility assessment and say, oh, they're never being seen in the ED, they're never being hospitalized, they're no longer eligible, they're going to drop right back into that previous pattern of frequent utilization. So I think the follow-up eligibility does need to take into account, have we modified their utilization because of the presence of this intervention?
Yeah, just to take an actuarial perspective on this, even if the answer is not necessarily because of the presence of an intervention, just simply they haven't gone to the hospital in the last 6 months, this may be something where, it's not a specific determination of the why necessarily needs to be made so much as if they aren't going to ER or observation center, inpatient, what is our intention for that? And again, this is going to have potentially a material impact on overall cost. The more stringent you have it, the less people will be eligible, the less program costs, but at the same time, having people cycling in and out may not really be optimal. So this is something where if you've got particular ideas on what your preferences might look like, that's something we'd really like to get some insight so that we can make sure that we're doing a level of modeling that we all consider to be appropriate for this type of analysis.
And I'll piggyback on that. Thank you, Matthew. Regarding the 2 tiers that the PASI model recommends, Tier 1 requires at least 1 unscheduled hospital utilization within the prior 12 months. So that could be an ED visit, observation stay, or acute inpatient admission. The Tier 2, for more the high complexity, requires 2, 1 hospital admission plus 1 additional hospital visit. And so to Matthew's point, and thinking about the continuity of care between these episode periods and the benefit periods, the tiering is something that we can also consider and model. Okay, I'm going to take this opportunity to move forward with the covered services. So similar to the clinical eligibility criteria, the types of covered services were outlined in the reference documents. It is assumed that both Tier 1 and Tier 2 patients will receive the same services. However, we anticipate that Tier 2 patients will receive more frequent services. And so that was outlined in the utilization section of the draft report. In terms of covered services, there's a core set of covered services, including an initial assessment. This initial assessment is intended to assess and manage the physical, functional, and psychological health of the patient. Goals of care, which is intended to discuss potential need for long-term care, when to seek emergency care, and the risks and benefits of hospitalization. Goals of care should be reassessed regularly as they may change over time. Advanced care planning is another set of services. This includes ensuring that the patient has a living will, a healthcare directive that outlines treatment options should they need that, as well as a durable power of attorney. Covered services also include cognitive impairment assessment to address cognitive impairments such as dementia, assessment of functional needs to discuss the practical consequences of their illness and their difficulty with the ADLs, the activities of daily living that we discussed earlier. Symptom management and medical care. This set of services is intended to assess and manage symptoms of the patient and the impact of quality life. Communicating with the patient's primary care provider and or the specialty care providers is part of the symptom management set of services. Pharmacy management where needed to assess medication in conjunction with their primary care provider or specialist. Caregiver needs to assess caregiver stress, capacity, and support. Behavioral health and psychosocial assessment and management of symptoms related to their serious illness. This may include standardized screenings for anxiety and depression. Spiritual care needs. This is intended to assess and discuss spiritual care needs. Ideally, this is done through a board certified chaplain with specific training in palliative care when available. This set of services is aligned well with the reference documents. And I wanted to pause and see if there's any comments related to the types of services that are included and whether you think that they cover the intention of this benefit.
Go ahead, Barb.
Yeah, so the word management would be one that I would want to know what all is included in that term. For example, pharmacy management. Does that mean that this benefit would be like the hospice benefit in that medications are supposed to be covered to manage symptoms, and or would durable medical equipment need to be covered? For example, if a patient with respiratory impairment needs a nebulizer, or are those going to be separately carved out benefits that would be covered as they would be for someone who isn't receiving the palliative care benefit?
That's a great question. As written, as interpreted by the reference documents, these services are more related to the assessment and coordination with the primary care provider and or specialist. And so as it's written today, durable medical equipment, pharmacy drugs are not included as it's written today.
Great, thank you.
Yes, thank you for that question about telephone support. I didn't mention it, but yes, in the benefit design, we do recommend 24/7 telephone support as a set of covered services. Thank you for pointing that out.
I was also asking about televisits. Like, how do we reach these people when they are bedbound and unable to come to clinics? Is there a way to do, are the televisits included in this benefit?
Great question. So as we know, palliative care and support services may be rendered by clinicians who are not typically independently bill payers, so nurses, aides, and these services are rendered in a variety of settings, so home being one of them. Right now, our intention is not to limit these covered services to any specific provider type or setting, such that telehealth would be included in our analysis of service cost. And the way that we are estimating the cost is we're taking a broad approach for estimating the average cost of these different types of services using non-palliative care services reimbursed today by payers. And we're using these services as a proxy as they're similar personnel requiring similar time and other resources. And so we're taking a broad approach such that we're not limiting it by site of service or provider type.
Sorry, I thought of another question. Caregiver support. Could you give examples of what is meant by that? Would that be providing, say, a homemaker and covering that through this benefit, or arranging for it?
Sure. So for the analysis and what we intend to do for the modeling exercise is there's an administration of a caregiver risk assessment. So assessing for caregiver needs is what we will be modeling.
So I have a question or two about basically how we take this list of services, which we're discussing, and turn that into your analysis. And I guess maybe it's kind of on the process of doing that. Matthew and I have talked in some of our calls about like how to specify the particular CPT codes, you know, that we're going to go into the all payer claims database and find that would be included in these services. I guess I'm curious how Milliman's process for taking these lists of services and then determining the procedure codes that are going to be included in the benefit, and then how we can make sure that the work group kind of has more specificity on this.
Yeah, let me chime in for a brief second, and then Sherry and or Carol can revise or supplement that. In terms of the CPTs and code details that we're going to be looking at, the big thing to keep in mind is, as Sherry mentioned, in actuality, we are going to see a broad range of services across settings and across provider types. Many of these would not really be present in today's data as known utilization. So what we have is basically we have research that indicates what utilization is likely to be like. We had broken that out by tier. And then the big thing that we're really using the APCD for is to evaluate what are reasonable approximations of the overall fee schedule, presuming a provider mix of physicians, nurses, chaplains, et cetera, across a variety of settings. So we look at CPT equivalents, but what this isn't going to say, for instance, is that the APCD is going to have all of the data on what initial assessments for people who have palliative care would look like, because many of these people don't necessarily have palliative care support. So we're really trying to combine different data sets to tell a coherent story of what is the likely utilization, what are the costs of these services, bring those together and say, for this patient, here's our expectation. For this patient who is a higher tier, here's our expectation. And then how many people are going to be eligible, and how do these things all blend together to say, here's our overall estimated cost of that benefit to be offered, both for commercial and Medicaid. Kids may be a separate conversation as well. Sherry and Carol, have I misstated, or is there something that should be supplemented to what I just described?
No, I think that's right. I mean, the goal is to understand what kinds of services are being provided in this benefit and develop like fee schedule proxies based on currently reimbursed services. They may not be palliative care services that represent sort of the types of settings, the practitioner mix, the amount of time needed. And so once we know those and we understand and sort of make some assumptions about the utilization for those of patients of various levels of complexity. And again, these are averages because some people will receive more and some will receive less, moving on from there. So it's the specific CPTs we may be using as those proxies are not really especially relevant to palliative care as it would be delivered into this benefit, and even the services. They're really chosen and placed to put together to represent the resource intensity and the personnel mix and the time required and the other resources required to deliver the services that Sherry described as being part of the benefit.
Thank you so much. That's really helpful. I only speak beginning actuary. So it's good good to understand that. Does anybody else have questions, comments, something you want to raise now regarding the list of services that Milliman has taken from the reference work to assume here?
I actually have another question about the assessment and management of behavioral health and psychosocial needs. I know they're talking about a multidisciplinary team. However, we're looking at psychological mental health issues. Do we then refer to outpatient psychiatric groups? It's not part of this benefit as well, right? To help co-manage a patient with mental health issues and palliative care needs.
For the cost modeling actuarial analysis, we're looking at the assessment of psychosocial and behavioral needs. We have not included the management of psychosocial and behavioral needs. That may be a question for your team operationally.
I think we have to be careful then the wording because we're saying management of behavioral needs. So behavioral health, mental health, piece, that's a huge beast. So we have to be careful on the word. If we're going to manage it, I think we have to include psychiatric care of some sort.
So one question I think, and maybe this is something for Milliman to consider, is that there are covered benefits that are already covered. For example, DME, prescription drugs, behavioral health. And I'm thinking what we don't want to do is inflate the cost of the hospice benefit or the palliative care benefit by including in that the cost of services that would already be covered under current law. So I'm a little bit, are there aspects of behavioral health treatment that wouldn't be otherwise covered that would need to be particularly called out in a palliative care benefit? Because if the therapy is medically necessary, and it's a covered service, does that take care of it?
I think that's pretty consistent with the way we would be thinking about modeling these. The assessment and referral is happening through palliative care. People are getting connected in ways they might not, or getting identified as in need of services. But I understand your point. The term management is from the other reports here, and we might, move away from using that term because I can understand the confusion about what is occurring under the palliative benefit versus what is assessment and referral, and essentially already covered. I think none of you would probably have an interest in like increasing the cost of this benefit for services that are already covered. And that would be probably in everybody's sort of best interest here. And so I think the term management appears to be resulting in confusion. We've used that from other reports that exist. We'll sort of modify that, I think, going forward. And if the committee is comfortable with the assessment and the referral, that part being carried out through under the palliative benefit, with the idea that for services, pharmacy, other types of therapy services that would otherwise be covered for patients who need them, those would be covered and carry on.
Yeah, for example, pharmacy management, I think it would be more clear to people if it said pharmacy evaluation and recommendations.
Mhm.
Or, yeah, and maybe wherever management is used, because again, that was the first thing I thought of as a former
Mhm.
provider is, what am I going to be required to cover? What does that make me sign up for as a provider?
Makes sense.
Great. So I'm hearing that we're leaning towards amending these terms a little bit, especially with management, to be clear. And certainly from my perspective, agree with what Carol and Jane were saying as far as services that are already covered, already billed under current law. Are there any objections to or further comments on this kind of line of discussion and having Milliman amend some of those parts of the materials in the analysis? So it makes a lot of sense to me. Okay, so hearing none, we'll go in that direction. This has been a great discussion. I appreciate how dynamic it's been and being able to go through and really scrutinize some of these past assumptions and reports. So let me turn it back to Milliman if you have other items you want to cover for us today.
I do, thank you. The next step after we've established a unit cost or a service cost for these covered services is looking at the expected utilization. And in the report, the expected utilization was informed by our clinical expertise, supporting literature, and experience from prior work related to palliative care. The frequency of services, as we've discussed, is going to vary patient to patient, and we anticipate patients with higher complexity tier will require more frequent visits. And as such, if you look at the utilization table, the number of services for many of the service categories, such as symptom management and ongoing management, is doubled for tier 2 patients. And so we will use this utilization estimate to model the cost of this benefit. And I wanted to pause to see if there's any comments about the utilization assumptions that we've made related to tier 1 and tier 2 patients.
Is that on this current page? Of
Yeah,
the
is there a
document?
different
Right.
slide we should
Yeah,
be
it's down.
seeing? Sorry.
Right here.
I have a question about other. Can you expand on what that means, other? Because it's high on tier 2. I was just curious what other as needed means. Other services, what would that include?
Sorry, I was on mute. So other services, we are modeling as with certain services for touch points or a kind of a low level office visit as needed. And as Matthew had discussed, as written, this is for a 6-month eligibility period. And so when you look at these services, these are units, and so not necessarily days. So for example, during an initial assessment on that visit for that patient, they may also be receiving information about their goals of care or advanced care planning. And so for the actuarial analysis, these are units of services that we've established as proxies for these services that will be modeled.
Any other reactions for
I-
now?
I just wanted to say or ask if this is somewhat fluid, for example, and I'll defer to Greg and Maura and other providers to say, you know, if one is say equivalent to one telehealth visit, say, maybe it might take 2 or a combination of telehealth and in-person to get a goals of care, advanced care planning topic covered, but maybe you wouldn't need as many, you know, ongoing management visits or what. It's sort of fluid, right, within this list. Yeah.
I think these is like an average, right? Think of it as an average for modeling purposes, and some patients will require more and some patients will require less, but we'd hope that on average, it is about right because it is the way you build the cost, right, of the services patients would require. I don't think there was any concept that this would be prescribed or like there'd be minimums or you need to do X or Y, but mainly for purposes of like the patients who would qualify in their clinical needs. Does this represent a reasonable average for patients in the different tiers?
My gestalt is that the numbers are overall pretty good. I do worry a little bit, particularly in tier 2, whether we're under emphasizing the goals of care, and in particular, because often there's more than one discipline involved. As a physician, I frequently will do something like a telehealth visit with a nurse on site, and there's so actually 2 different disciplines simultaneously involved as we're doing an in-depth care, goals of care discussion, or perhaps a social worker and a nurse practitioner on site together. And so that would be one area I would consider maybe expanding.
Yeah, I agree with Greg. It can take more than one provider, one clinician to have these, and they can be lengthy, so they can be time consuming. So I think expanding on that is a good idea. I support Greg.
And expanding, you mean increase the frequency
Increase
of
the
visits
units,
for
yeah.
both? Okay,
Mhm.
thank you.
Great, thank you. We'll consider that.
If there are no further questions related to the clinical eligibility criteria or the set of covered services, Shelley is next up on the agenda.
Thank you, Sherry. My job today is to discuss, as was outlined in the statement of work, who can deliver services for palliative care, who are the players on the team, where are the services typically provided, and then what are the opportunities to measure the efficacy or the impact of the services. So we took this in two parts. The first, we talk about appropriate staffing and staffing models, as well as provider training. And then again, in our second piece, we'll talk a little bit about the evaluation criteria and reporting. So with respect to team composition, as the BREE Collaborative highlights, both primary and specialty care providers can deliver palliative care services for this complex population. Just briefly, as Sherry has already outlined, an interdisciplinary palliative care team would typically include physicians, advanced practitioners, nurses, pharmacists, rehabilitation specialists, psychologists, social workers, and clergy. This is typically the foundation of a palliative care team, and it ensures that individuals get the holistic and patient-centered services that they need to address all of the aspects of care, physical, emotional, and financial, that can arise during a serious illness. When we talk about staffing models, there's typically three that are referenced. Those are in the hospital, home or communities or clinic-based settings. And so in a hospital-based setting, again, based on the institution, there may be institutional variability. There's a consultative model where the primary care team maintains responsibility for the patient's inpatient stay, and then the palliative care consults with the primary team. There are embedded or integrated models where there is a palliative medical or advanced practice staff, and they are fully incorporated into a specific unit, such as oncology or intensive care. And then finally, there's what's characterized as a palliative unit model, where there are specifically assigned beds which provide care from a dedicated team, and that again can include clinicians, behavioral health, and other specialists. Typically, these are more resource intensive than the other two models and are more practical in larger or higher volume facilities. When we talk about home-based palliative care, as you've all discussed, there are a couple of models here. There are those that can be typically led by a nurse practitioner with a physician providing oversight, or there are also teams that are led by registered nurses with a physician or a nurse practitioner providing oversight of that group. And then there are also mixed models. And again, those are all going to vary based on availability. And of course, how many patients that team is going to be able to manage is going to vary, again, based on location and who's leading the model. When we talk about clinic-based palliative care, these are typically standalone palliative care centers or integrated palliative care centers. The standalone clinics, they operate independently. They maintain a dedicated staff that's really exclusively focused to design the needs of a palliative population. Whereas in an integrative care setting, these are clinics, this is a function within an existing primary or specialty care clinic. These programs can benefit from operational efficiencies that you don't necessarily get in a standalone clinic, but again, all based on local factors and local institutions. If there are any questions, what I'd like to do is to move on and talk a little bit about how we evaluate palliative care services. There are a couple of sources to look at data. This can either be claims data, chart audits, surveys of either providers or participants. Using a multidimensional approach helps you evaluate a wider variety of of variables, obviously. When we talk about healthcare performance measures, typically we break those measures up into 3 groups. Structural measures, which describe the availability of settings or facilities and resources that are available for care. We also talk about process measures, and those are the measures that really reflect the methods and the procedures for delivering care through healthcare activities. The intent of process measures might be to provide evidence that there is person-centered communication or systems integration that you're looking for in palliative care. Some examples of measures might include the number of patients on a specific unit who get assessed for palliative care, records that evidence engagement with, say, another team, psychosocial services, screenings, or as Carol and Sherry mentioned earlier, the existence of specific documentation. And then finally, there are outcome measures, and outcome measures determine the results of the intervention. How did the service impact the patient and the caregiver? And, obvious metrics here include things like pain control, satisfaction with care, utilization of healthcare services, and perhaps the costs of an episode of care, or however you end up defining this sort of bundle of services that characterize palliative services. I'm sure you're all familiar with, you can either perform quantitative or qualitative evaluations. And then finally, just touching on some of the domains for palliative care, some of the things that you evaluate. As was echoed in the BRIE Collaborative and the Washington Palliative Care Reimbursement Summary. Key domains can include, again, structure and process of care, the interdisciplinary team, physical aspects of care, psychological and psychiatric, social, spiritual, cultural, end of life, and then ethical and legal considerations. So I think I'll pause and just make sure if there are any questions from the group.
Hi, Shelley. So kind of a clarifying comment and partial question. Matthew and I in meeting, to get this project started, have talked about these various parameters that the legislature is directing us to look at as part of this work.
Mm-hmm.
And my understanding from Matthew is the staffing and the performance measures that are the valuation criteria are a little less relevant to the actuarial modeling that Milliman is doing.
Mm-hmm.
However, we are endeavoring to include these pieces in our reports. Could you confirm if that's accurate, or share how Milliman feels that there's the connection between the staffing and the evaluation criteria to the actuarial analysis?
So I think what I would do is want to connect with the Milliman team in order to fully answer that question. If I understand your question correctly, you want to understand how the actuarial analysis relates to providers and to the process of evaluating the palliative care services. So we can certainly connect and make sure that we're answering your question, Nico.
Thank you.
Sure.
I think it's more of making sure that our work group members have an understanding of like the parameters that you're kind of building into this modeling versus the ones that we're going to list in our report and discuss, but have less of a bearing on it, if that indeed is true.
Shelley, would you mind if I take a stab at
No,
this?
absolutely, Matthew.
So what I would say is a lot of the things that Shelley is covering right now aren't directly feeding the actuarial modeling of, this is how many people will be eligible. This is the cost per member per month or per episode or something like that. But my understanding is both that this is information that was requested as part of the RFP, and also that this is potentially useful for establishing considerations around setting up this benefit. So it's not just, what do the numbers say? What's the actuary report? That's it. but creating a larger and complete picture of here are the considerations, here's the staffing. We talked about, one of the things in the report got into, there are shortages. Those shortages are particularly acute in the rural areas. These are the things that potentially need to be addressed in order to have the palliative care benefit, assuming the state decides to do it, operationalized in an effective manner. So our understanding is basically this isn't just an actuarial report, but a more comprehensive report. And that's why we're including this information, to make sure that you've got all of that data, not just here's the numbers. Shelley, did I misstate anything, or would you like to supplement that, or is that pretty consistent with your understanding as well?
No, thank you, Matthew. That was very consistent with my understanding.
Okay, thanks, Matthew and Shelley. I apologize if that was unclear or confusing. I think I wanted to make that point to our work group members on we're including this, but it's not directly being like assumed for your actuarial analysis. I think that's why, rightly so, we focused a lot of the conversation today on clinical eligibility criteria and included services, because those very much do drive, right, your analysis. You need to make certain assumptions, right?
Yeah.
Okay, great.
Well, I
Greg,
think
go ahead, Shelley.
I was just going to say, I think I've hit on the high points. So I'm happy to turn it over to the remainder of the team. Thank you.
I just want to acknowledge Greg's comment in the chat about the map. Yeah, we can absolutely look at that. And Greg, if you have any, I don't know, sources or links you want to share too, we could absolutely try to make that accurate if you're finding issues there.
And sorry, go ahead, Greg.
Just out of curiosity, what was the source of the data?
This was publicly available data, and I would need to go and quickly look at the reference, but we can certainly make sure that it's meeting your needs.
Yeah, and if there's updated data, we can certainly take a look at that. And one of the other things we would note here is that, as an example, there are some providers who aren't explicitly registered as palliative care as their specialty, but some of their CE continuing ed training may cover palliative care. So in that sense, there may be people who can provide palliative care services, but would not be covered by this type of data search. So again, it's not going to be perfectly accurate, but we are trying to establish, here's what the data says, here's the broad picture of, hey, there's a lot more concentration in the Seattle area. In a lot of these rural areas, there's generally much more of a shortage, and this is relevant for how a benefit might be provided in practice. So for instance, if you just say, we're going to provide a palliative care benefit, if there's no providers in that county to provide that benefit, that's another thing that needs to be considered. Perhaps the funding that is created by the benefit may attract providers, and that might engage the problem by itself, but there may be other considerations needed in order to make sure that there would be enough providers to actually furnish this benefit in practice.
Well, and that gets to a core question, Matthew, of what level of specialization or certification would a provider require in order to provide the service and be compensated with this benefit? I come from a family medicine background, and when I was doing full spectrum family medicine, because I had an interest in palliative care, I probably did a better job at palliative care than your average family doctor, but I'm not sure that I was really providing specialized services until I did additional training. And so maybe at the least, I don't know that we want to limit it to board certified, because that's going to really narrow the work pool, but at least stipulating that some added level of training through CME or something of the sort, CEUs, to demonstrate that this person has a higher level of interest and expertise in palliative care could be an appropriate requirement for the staffing models.
Thank you. I think that's a helpful comment. I appreciate that. Carol or Shelley, did you have something you'd like to add to that response, or we'll just take that back?
I think we can take it back in the sense that, like, being prescriptive can definitely be challenging because it can impede access, as you've
Yeah.
described, but
Yeah.
yet requiring some level of capability or sort of training helps ensure that people are getting or more likely to get under the benefit what you believe is high quality care. I mean, that's a
Yeah.
constant tension, I think, that exists for this type of benefit.
Okay, at this point, we have the time blocked out until noon, so I'm gonna throw it open, I guess, in general for everything and anything you've heard today from our Milliman colleagues. Throw it open to the work group to ask any more questions broadly or comments, and then after we do that, I'm gonna reiterate our next steps. So throwing it open once again for the work group on anything Milliman presented today. Okay, well, like I said, it's not your last opportunity. What I'm gonna do after this meeting is send this draft out once again to our work group members, to your emails, and please feel free to review it. You can send me any further feedback you have. I think we've gotten really good feedback from today, and shows that there are at least a couple areas where we do want to adjust and change the framework that was done by the BRE Collaborative and OHSU. So let me just put an email in the chat here. We have a website set up for this work group as well that has all the previous presentations and the meetings. And this meeting is being recorded, so we all have the benefit of being able to go back and look at specific parts of the discussion. So that's the immediate next step, is getting your feedback additional to today. And then in the next few months, we're going to continue working with Milliman, including getting them access to the APCD data set. I'm also going to try to plan out our future meetings. There will be future work group meetings as we get to next steps. I think one of the conversations we still have to have is about payment methodologies. I know Milliman is working on that. That will be very relevant to this. So for now, again, asking for additional feedback. You can email that to me. Happy to set up calls with anyone individually, and really want to make sure that everybody's involved in having a voice in this work. And then there will be some future meeting invites for me as we continue in the summer and fall here. So those are our next steps. That's our process. Grateful to the Milliman team for detailed presentations and thoughtful answers, and work group members for really great conversation. I know this is very complex. As a non-clinician and non-actuary, I'm very, humbled by the expertise that my colleagues in this line of work have. So thank you. Any other questions, comments from anybody before we adjourn?
I'll just say, Nico, I really appreciate the time and energy put into this. It's really been helpful, and I want to reiterate the thank you to everybody on the committee the work group, for your thoughtful questions and comments. I think this is really valuable to us to make sure that this is going to be the best and most appropriate analysis for what the state is looking for, to ensure that if they do move forward with this benefit, it's as effective and appropriate as possible. So just want to thank you all for everything you've done here, and looking forward to continuing to work with everybody as we continue to move forward.
Great. Thanks, Matthew. Okay. Thanks, everybody. Hope you have a great rest of your week. Great weekend. Enjoy the spring sun out there.
All right. Thank you.
Yep.